Okay, so anatomy of the forearm, we have already talked about how this is very similar when comparing the lower leg. So the elbow and the knee, both hinge joints, the tibia, the fibula of the lower leg, two parallel bones, the forearm, the radius, the ulna, again, two parallel bones running beside each other. The femur being that upper thigh bone, the humerus being that upper arm bone. Again, very similar in a lot of the structure in the function. So again, taking another look at some of our anatomy here. Again, don't confuse the medial and the lateral sides. The proximal end is going to be that top part. So the proximal end of the radius and ulna, closer to that elbow, that head of the radius is what's spinning when we pronate and supinate. So as our hand moves around from this, again, it's not a waving thing, it's just a twisting of that elbow, but you see that action at the wrist, even though it's actually occurring at that elbow. So it's the radial head that's spinning in place, the annular ligament helping to hold that down. The most distal end of that forearm will be your radial and ulnar styloid processes. So these little nubbies on each side of your wrist, the radial one on the thumb side, the ulnar one much larger on that ulnar side. Again, those little nubbies, that'll be the distal end of those bones of your forearm. Up at your elbow, so the actual elbow joint, part of the ulna, the tip of it. So if you're to fall right on the tip of your elbow, on your olecranon process, you might get olecranon bursitis. Already talked about that quite a bit as well. So slide number 52 here, again, looking at some of the anatomy. We've already talked about this in regards to the elbow, the triceps doing a lot of your elbow extension, biceps doing elbow flexion, and then some of your wrist muscles, so the ones that allow for wrist flexion, are going to be on that medial side of the elbow, and the ones that control wrist extension are going to be on the lateral side. So when we already talked about medial and lateral epicondylitis, that tennis elbow, that lateral epicondylitis, again, repetitive wrist extension causes those muscles to tense. So if you feel even on your own, when you contract the muscles in your forearm to allow for wrist extension, they're going to become more prominent on that lateral side. When you go to flex your wrist, you'll feel those muscles on the medial side become a little bit more prominent. So again, based on the location of the pain, you can have a really good idea of the mechanism of overuse and what's causing that injury to get a little bit worse. It will also help guide you in your treatment or any braces, protective devices, things like that you might want to give your athletes. The muscles that allow for pronation and supination, we'll just simply call the pronator group and the supinator group. So looking at some of the assessment, again, it's the same history questions that we would ask for mostly any other injury elsewhere in the body. The what happened, when did it start, how long does it last, describe your pain, is it sharp, dull, achy, throbbing, stinging, burning, does it radiate, where to, what increases your pain, what decreases your pain, how it affects your activity level, have you seen anyone, what did they say? I mean, if you can get a really thorough assessment in the history, you'll have a better idea of not only how severe their pain is or the why they're getting it checked out now rather than 2-3 weeks ago when it started or something like that. But then also a better idea of treatments that may or may not work for them. Have they tried medication? Have they tried the price principle? Has it made things better or worse? Again, that can also help to tell you a little bit about some of the structure too. Is it something that ice or heat is going to help, or is it something that doesn't really respond to a lot of your thermotherapies? Observation, again, just taking a peek at what's going on. So if there's any definite deformity, so we know some structural differences right and left side could be fairly normal, especially for our overhead athletes or upper extremity athletes where they're doing a lot, maybe with one side more than the other. They might have a little bit of increased motion or a little bit of a difference in some of the structural stuff just because that side is getting a little bit more use. Might have a little bit more muscle strength, but then also the ligaments maybe being a little bit more lax. Things might sit or hang a little bit lower on that dominant side, but you should still be able to see any type of swelling, skin irritation, redness, again, any rashes, any signs of the pathology, the bruising, lumps, masses, spasms, bones sticking out. Again, not necessarily something that we're going to attempt to manipulate, but just something to note in the report. You can very objectively see what is or is not there. The palpation would be the feeling around for any kind of point tenderness, edema, which is just our swelling, fracture deformities, Skin temperature changes, so either it's cold potentially because there's a decrease in blood flow, or it's really hot because there's an increase in inflammation in the area. Bone fragments, lack of bone continuity. So if you feel down the arm, it's a nice straight line, and then you feel a big divot, it could be because that's where that bone has fractured and it has displaced or moved from the rest of that stable bone, and that's what's causing it to look a little bit different or be angulated, that we already talked about for vacuum splints might be best treated by something angulated. Looking at, again, some more of our more common injuries are contusions, sprains, strains, fractures. Again, it's the same mechanism of injury for most of the other places in the body too. Our contusions, getting those mostly again from direct trauma. So this is basically just a bruise, usually not too severe. Now, when thinking about just the forearm itself, the ulnar side, so the medial side, when we're talking about anatomical position, that medial side is going to be the most vulnerable to contusions just because it's not very well protected, and it's going to be the main way that you try to protect yourself for any type of upper body trauma. So if something's coming at me, I'll try to protect myself and shield my face to kind of get small and curl up in a ball. So that ulnar side is going to receive a lot of the blows due to, again, that acute trauma, something coming at it. We'll talk about forearm fractures in, I believe it's the last slides, but there is a specific type of fracture called a nightstick fracture, where we see it's caused by direct trauma from someone usually, again, getting hit by what could be a nightstick. So some type of defensive wounds usually. Again, with any type of bruising, it's not the end of the world. It's not the worst thing to happen. But again, if we're thinking that a lot of the muscles that allow for your wrist and your hands to move will actually be in the forearm, you'll have a lot of fatigue with that. So it'll be really painful to have this contusion just because that means that there's going to be extra swelling right on the muscle tissue itself. So a lot of the treatment in this is just helping to resolve the signs and the symptoms that's already there. So their pain, the swelling, the actual bleeding under the skin, trying to find ways to get rid of that can help the healing process. So in the short term, again, our ice might be really beneficial. Later on, if it's still just some of the byproducts of the healing process just kind of linger, that swelling's not really helping us anymore. We still have, again, maybe a little bit of muscle spasm in the area. We could do a little bit of heat, some gentle massage, gentle stretching, things like that, just to help them get back a little bit faster. But again, in the acute phase, we're looking at our price, our protection, rest, ice, compression, elevation. A lot of that stuff's even going to be good for prevention mechanisms. So if they are having a little bit of pain and fatigue, that little bit of compression in there might actually make it feel good enough to at least get through the practice or to get through the game, and then they can address that later on. A lot of your neoprene sleeves will also have a little bit of padding in them. So elbow pads can be worn a little bit lower, or just sleeves with hex pads in them can be a little bit more protection. So we don't get, again, some of that buildup of muscle bone within muscle tissue, our myositis ossificans. We don't want to see that develop. So if we can prevent especially repetitive blows to muscles, that's going to be the best way to prevent that from even happening in the short term. Next, moving on to our forearm splints. Now, again, if we're thinking upper body, lower body, very similar structurally. In the shin, we have shin splints. So our forearm splints would be, again, a very similar condition here, where we're seeing some of the tugging on the muscles in the area from that bone itself. So it's going to be an overuse type condition, but instead of running that's causing that, we'll see this caused from repeated static contraction. So the muscle contracts, but the length of it doesn't necessarily change. So what we'll see is someone usually holding themselves in wrist extension. So they're either holding something up above their head for a long period of time, or kind of on the flip side, they're pressing down for a long period of time. So especially your gymnasts, your tumblers, even divers that are learning new techniques and skills where they're in wrist extension for a while and they're holding themselves, we can see them again have some of the overuse of the muscle groups in that area, and again have some of those micro traumas that's going to be basically a dull ache, a dull pain. Again, it's going to be a nagging condition. It's not going to be something super, super serious, but it might feel intense because those muscles contract when you move your hands and your wrist. So you'll notice it with a lot of the daily activities. You're loading the dishwasher, you're putting dishes away, you're opening doorknobs, you're driving your car, you're picking up your backpack, you're writing your notes. Again, a lot of that daily stuff we don't think about being especially aggravating to wrist and forearm injuries, but it's definitely going to make it worse if we're using that more than we should. So a little bit of prevention might be helpful. If we know that they already have some weakness, we can do some training before they even have to undergo a lot of these contractions, but we can also try to just limit that motion in the first place. So especially athletes that are going to have to push a lot or have those static contractions and wrist extension, we can tape them in a way to where the wrist will be braced and supported. It doesn't have to work as hard to go into extension because it's going to be more stable. So that's something that a variety of different taping applications can do. Again, cheerleaders, when they're stunting, when you're holding someone's entire body weight on your hand and you're the only thing that's keeping them off the ground, that's not the time to have weak floppy wrist. We've got to be ready for that. So if we need a little bit of stability, there's nothing wrong with that, just as long as we're not using that as a crutch. We're doing everything we need to do in the training room to make sure that we're building up the proper strength and range of motion. We're still able to do what we need to, but we also are going to be addressing these things if they do start to happen, just so they don't get out of control. And it's something that we're having for the long term and most of the season. So the last thing in this elbow forearm slides that we'll talk about are forearm shaft fractures. Now, if you think back to elementary school, the coolest thing that you could have was braces and a cast, right? So kids would sign your cast and you were, kind of mispopular there for a while. So I, knock on wood, never had braces, probably needed them, didn't get braces, and I never broke my arm. So I didn't have a cast, not really something that I was real jealous of. But we see kids especially have a lot of forearm shaft fractures just because of falls. You're climbing trees, you're jumping out of trees, you're wrecking your bike, you're, fighting with your brother, just things happen. And if you're sticking out your arm to try to catch yourself, again, that whoosh mechanism may fall on an outstretched hand. If that force is coming down and something lands on you, pretty easy for that forearm to break. Now, especially with kids too, we have to think that they're the only group that's vulnerable to a green stick fracture. So instead of that bone just like clean break in half, it'll kind of splinter in place. So when it does break, it's not to the point where it's lost a lot of its stability. It probably won't be as displaced. So with kids, again, it may not be out of place very far, but they'll have a lot of pain and weakness in it that will warrant the ER trip. Now, in adults, you'll usually see a lot of that displacement or it be nice and in line and then just kind of drop off, right? So they may have heard a pop, a crack, again, have some of this disability, the inability to move their fingers or their wrist or their hand, a lot of pain with that. Again, if it is a displaced fracture where it's limiting oxygen and blood supply to the muscles later down on the hand, it could cause the hand to almost spasm in place and you have a kind of like some funky claw hands just as they kind of start to shrivel up. So it's something that should not be avoided. Once you have a fracture, definitely go get it checked out. If you're a younger, healthier person, they may be able to just cast it. Even now, casts aren't what they were in the 90s, right? So back when I was growing up, it was plaster casts that were heavy and stinky and gross, and you just, wore them for 6 weeks and it was just kind of a pain. But now, with advances in 3D printing and a lot of heat moldable plastics, they can custom make you a brace or a cast that's going to be easier to take on and off. So you can take it off if you decide to go in the pool, or when you're taking a shower with an old plaster cast, if it got wet, it would just stay wet and be kind of stinky, and it was not good for your skin, bacterial infections, stuff like that. They were really itchy, again, because of some of the bacterial growth on the skin from sweating and things like that. So again, cast aren't as bad now as what they used to be. So you're not really saving yourself anything by trying to let it heal up on its own, because if it does fail to heal correctly, they'll have to actually re-break it to properly set it to get it to heal. So with forearm shaft fractures, again, this picture in this next slide is in your book, but when it displaces, there's a couple things that could happen. So again, if it breaks through the skin, it's going to be a compound fracture or an open fracture. These ones can be really serious just because now we have this large open wound, very vulnerable to bacteria and things like that. So in addition to the casting and maybe ultimately surgery, you're going to be on some antibiotics just to help to prevent any infections from bacteria that might result from that fracture itself. Usually it takes bone about 6 to 8 weeks to heal. So after they cast it or fit you with a brace, you'll keep it on for, again, a period of time. They may re-x-ray just to see that bony callus form, that osteoblast activity, to show that that bone has actually built up in size and strength and that it is trying to heal. If it's not, in some cases, they may need to recast it. They may need to give you like an ultrasonic bone stimulator. They may eventually have to do surgery if it doesn't heal properly. But when it fractures, again, it could displace in a couple different directions. Now, I'm not super concerned that you know the difference between what's called a Colles fractures versus a Smith fracture. Again, it's a lower arm fracture, but as far as what causes it, if it's caused by a fall on an extended wrist or a fall on a flexed wrist, that's going to cause it to move one way or the other. So with the Smith fracture, falling on a flexed wrist, again, it's not as common. We don't see these as much, but the displacement occurs anteriorly. So we have the bone shifting anteriorly versus a Colles fracture moving posteriorly. Now, again, there's some special fracture names for all of this stuff. Just usually named after the doctor that, hey, I'm going to call this a Sally Miller fracture and I'll get all the money from all these. I mean, it's not as popular now, but you may also have heard of a Barton's fracture or a reverse Barton's or reverse Smith, reverse Colles. When you're looking at those three things, it's essentially all the same thing, just looking at what direction it displaces when it does break. So again, not super, super scary to have. Usually it's not going to have any severe long-term effects if it's handled properly at the get-go. If it's not, then again, you'll have some issues later on, but very easy to treat if you go get that treated. Last thing, yeah, so we'll move on to hand and finger pathologies. It'll be in a part 2 type thing. So this concludes the end of the elbow forearm unit. We'll start wrist, hand, fingers, and thumb in the next recording. So stay tuned for that one.